Hello, everyone, and welcome to our third episode of COVID and Coffee, Social Justice Now. I am delighted to have Dr. Erica Reaves, class of 2000, join us. Erica is a public health practitioner, and I'm sure for those of you who may not be so aware of what that is, Erica will give you a little insight to that. Today, what we are discussing is health disparities and the social determinants of health. So I am now going to turn us over to Erica, but however, before that, I just want to say again, folks, that if you are not muted, please do mute yourself. And I'm very, very, very excited, and I'm so happy that you're here and with us today. It's going to be very exciting. And without further ado, Erica.
Can everyone hear me? If not, shoot me a note in the chat. But Eris, thank you so much for the invitation to participate in this series, which I think is both timely and timeless. And these are very important conversations to be having in our homes, in our communities, in our workplaces. So thank you for all of your efforts. And to anyone who's representing the school today, thank you for supporting this series. And again, thank you for the invitation. So I have what I hope is not too much of an academic presentation today. I really want us to have a discussion and share reflections and observations as we talk through what are very heavy topics. And so with that, I will ask you to reflect on a question. Just for a moment, how do you define health? And I'll just pause for maybe 30 seconds to give you a moment to consider how you define health.
A state of being.
Okay. And feel free to share or not, or jot it down, or if there's a chat function, please, feel free to share in the chat.
A state of being well.
Mm-hmm.
Yeah, I associate it with wellness.
And with that, I'll take us to the next question. Many of you just touched on this very point, but want to make a difference about the distinction between health and well-being. How would you define well-being?
Holistic health, mind and body connection of being well.
Any other thoughts?
Filled with energy and also with peace.
Well, thank you for sharing those reflections. So I offered those two opportunities for personal reflection to get us started today, to really drive home the point that health and well-being is felt on both an individual level. We all define it differently based on our experiences, but also there's health and well-being at the community level. And that is the level at which I work as a public health practitioner. And as Eris mentioned, I'll get into more of that later, but just wanted to start the session off by saying that I respect that we are a group of individuals with different ideas and experiences, and there's room for all of that in this conversation as we move forward in thinking about health and wellness. So I want to offer a definition, again, saying that definitions change over time and definitions change on who's doing the defining. But the World Health Organization defined health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And so I'm sure it comes as no surprise that human health and well-being are informed by multiple factors. Some of those factors are fixed, some of our biological factors. We inherited what we inherited in terms of DNA, but there are indeed modifiable factors in theory. And these are social, economic, political, environmental, and behavioral in nature. So the context into which you were born, or which you live, or which you work, can change based on where you live. And where you live is influenced by all of the factors listed here. So I would suggest that the World Health Organization, which is the preeminent international organization working on health, and you may have seen WHO, as it's called, in the headlines recently, given a proposed change in the relationship between the United States government and the World Health Organization. But I would say this definition is at best incomplete because of the word complete. So it doesn't account for people who are managing chronic conditions, but otherwise have reached a level of health that is somewhat stable. And it doesn't address people who are living with physical or cognitive limitations and their efforts to maximize their level of function. It doesn't account for your health risks or outcomes. It doesn't account for access to medical care, which we know is different depending on where you live. And it doesn't account for access to your social network. So your friends, your family, your neighbors, all of these people contribute to a sense of health and well-being. And so often when we talk about health, we focus on these physical, mental, and social aspects, but I would suggest there are other aspects that impact health that are not always considered, and they should be. So looking at the health continuum, all the way from personal or individual on the left, which is really what happens when you go to see a physician or a nurse practitioner or physician's assistant, the care that you would receive in a hospital, decisions you make about your activity level or your dietary habits, those things really happen at the individual level. At the other end of the continuum is what happens with health in terms of at the community level or public health. And this is the space I work in. So I don't have any clinical training. I don't see patients. I work on community level interventions. So for instance, fluoride in our drinking water is a community level intervention. Vaccinations for school-age children is a community level intervention. I also work in the space of community-based participatory research. And that's research that says, we don't define what the issue is in a community. So we're all familiar with Bexley, let's say. So if I wanted to do research looking at an aspect of health in Bexley, a community-based participatory approach would say, I would include the residents of Bexley to help me understand what the issues are, so don't make assumptions about the issues, and also to include them in proposing the solutions. And so also out of that research comes awareness campaigns. So you may remember DARE or Say No to Drugs, or the very active campaigns happening right now about hand washing and wearing masks. Those happen at the community level, although the impact is at the individual level. And so taking all of those into consideration, I would think that most people assume when you think of the word health, you think of medical care. Again, what happens in your doctor's office or at the minute clinic or in the hospital. But medical care, those encounters with clinically trained individuals really only account for 10 to 20% of the factors that influence your health outcomes. So those are mortality, morbidity, your length of life, your quality of life, and your healthcare expenditures. So that leads to the question, well, what accounts for the remaining majority, the 80–90%? And those are the social, economic, political, environmental, and cultural conditions in which we are born, in which we grow, in which we live, in which we work, in which we age. Our health status is much more a reflection of our environment than it is of our access to care, but obviously access to care is very important. So I offer this model, and I will offer several models, and this is not to ask you to read all of this or digest all of this, but just to say models are a very effective way to summarize a lot of information in a colorful manner But also, as we get new information, we can feed that information into models to question our assumptions and to question our findings from prior research. So I have, considering the full picture and full in quotations, because of course this is not a full picture, this model would be different for everyone in this chat because we are experiencing different factors in different ways. But this is, again, just to illustrate that there are program and policies which influence health factors, which influence health outcomes. And so you have your physical environment, your social and economic factors, clinical care, and also your health behaviors. So I will share this later, and again, it's being recorded for you to spend some time looking at this if you'd like, but this is just a model, again, to summarize all of the different factors that feed into health and health outcomes. So again, another picture, this is called an infographic, a way to capture, again, a lot of information in a picture. And this comes from the campaign, Let's Get Healthy California. And the idea here is to consider place-based influences on health outcomes. It turns out that your zip code impacts your health more than your genetic code. And that's what this picture is trying to convey. That at the top we have healthy people. This is individual health, but healthy people are supported by healthy communities. Healthy communities are supported by healthy environments, and healthy environments are supported by a healthy society. So some place-based influences on health outcomes are listed on the left and the right. So to the extent that there are opportunities for health prevention services, that you have access to mental health services, that the services are culturally and linguistically appropriate. So if you are someone who is primarily Spanish speaking, but all of the services available to you are in English, that's obviously going to impact your ability to access those services. There's income security, obviously housing, neighborhood safety. If you're someone who doesn't feel safe walking in your neighborhood, perhaps walking is not an option for you in terms of exercise in the evenings due to poor lighting or other factors. Of course, environmental quality. Do you live near a plant that gives off, toxic waste? And what does that mean for your groundwater? What does that mean for your soil? And on the right, of course, healthcare, opportunities for child development and education, food security. You may have heard the term food desert to describe neighborhoods where individuals don't have access to, let's say, fresh produce. And then what does that mean for nutrition? If what you have access to is high caloric, less nutritious food, of course, that's going to impact your health. And then the built environment, how we build buildings, how we build houses. What does that mean for the ability to build community or for the ability to feel safe? And then, of course, and we'll get into this later, discrimination that's based on, identities, including being a racial or ethnic minority. And so, again, building on this idea of place-based health, I wanted to offer two maps from the Robert Wood Johnson Foundation to drive home the point that where you live impacts life expectancy. So I lived in Baltimore and then just outside of DC. So I'm very familiar with this map, and some of you may be as well, if you lived in Maryland or Northern Virginia or DC. But it drives home the point that, and I don't know if you can see the scale at the bottom, which is about 2 miles. So from end to end, I would say maybe 10 to 12 miles difference between the orange line and the blue line. So these are the metro lines or the subway lines in DC. You'll see that there's a 6-year difference in life expectancy, just based on where you live, just 12 miles away from someone else. And so I think it's worth stating that the 78 years, the blue line, which goes out into Prince George's County, is largely a county comprised of African-American individuals, a very large county, whereas the orange line and the red line are more affluent areas of Virginia and Maryland, respectively. So the Robert Wood Johnson says that babies born to mothers in Maryland's Montgomery County and Virginia's Arlington and Fairfax County can expect to live 6 to 7 years longer than babies born to mothers in Washington, D.C., just a few subway stops away. And then moving to a map of New Orleans, you see just in this one picture, a disparity of 25 years in life expectancy, just in one metropolitan area. And I should mention this is from 2013. So here, the Robert Wood Johnson Foundation asserts the average life expectancy for babies born to mothers in New Orleans can vary by as much as 25 years across neighborhoods just within a few miles apart. So again, where you live has the ability to impact life expectancy. And this is not 50 years ago, this was 7 years ago. This is what it looked like in New Orleans, Louisiana. So another opportunity for personal reflection, again, building on this picture, if you have any thoughts, of course, you can reflect in silence or share here. Any thoughts on how your zip code impacts your health and well-being?
Access to services, public services.
I'll share. I know in my area, I don't live in the hood, but I don't live in the suburb either. And so, Erica, when you mentioned about just walking in the evening, I've never even thought about this as a health issue, but my boys have literally stayed inside this entire quarantine, except maybe every other weekend when we go visit my mom who lives in New Albany. And when we go over there, we run around, we're outside playing. But in my area, we don't go outside at all. And I never thought about it as a health issue. I just always, I'm like, this is what it is. This is the area I live in, and I don't feel comfortable letting them play outside, like in the front yard. People drive too fast. I don't have a park nearby. So that was just interesting. I'm like, dang, it is a health issue. That's horrible.
I think I would add from down here in St. Petersburg, Florida, in our zip code, we can actually ask the city to come and spray for bugs to combat things like West Nile and Zika and others, whereas some of our neighbors that are across the bay in different parts of Tampa don't have that option. So from a community perspective, if you think about mosquitoes being the leading killer in the world for disease, I think that's one that certainly resonates down here.
Hi, everybody. This is Brandy. I live in Linden, but I'm also rehabbing a property in King Lincoln. And the King Lincoln property is a family property where I kind of grew up. And what I know about our community is lead-based paint, because many of the buildings are old. Asbestos, a lot of the things that I'm having to remediate for. Some people just rent these homes and have no knowledge of how that impacts their health. So that's something that comes to mind to me pretty quickly.
Hi, for me, I think about the dramatic, I'm a principal of a school in the Bronx, and I think about the dramatic difference in my childhood in Bexley and playing outside and playing capture the flag, and my students who mostly stay inside. It's sort of what Mashawn said really resonated. And I also just think about the fact that my school building this year was an old bowling alley that had no windows, no play space, no gym. So our kids had physical education in a cafeteria. We had to walk them 5 blocks to play outside for about 10 minutes at recess. So just thinking about those huge disparities that I experience every day that are so different from my experience growing up.
Any other thoughts or reflections?
I would share that I live in Brooklyn, New York, and certainly Brooklyn, New York is a world apart from Bexley. And it's a world where your zip code means a great deal, because Brooklyn is a huge borough, many people, and with all of the things that we have been fighting in our lives today, parts of it are very dangerous to your health. There's been a lot of violence, there's been shooting, there's been acting out, and it's a very troublesome time.
Thank you for those reflections. Oh, sorry, please go ahead. Hi, Abby.
Hi. I guess something that comes up for me, which you mentioned already, but is around food deserts. I moved cities within the last year, and for me, you know, a big factor in figuring out which neighborhood to move to was access to fresh fruits and vegetables, and how different that can be neighborhood to neighborhood and the cost of those things. And I look at that as, like, I very much believe food is medicine. And so it's fundamental to your ability to participate in society and community and do your job and go to school. So to me, it's a huge fundamental part of health and access.
Any other thoughts? Okay. Interrupt me if you think of something. We can come back. So thank you all again for those reflections. And so I wanted to come back to this idea of health as a human right. I mean, hearing all of your personal reflections about, you know, where you grew up or where you currently live or what you're seeing with neighbors and family members, but also the maps of DC and New Orleans, and knowing that, you know, in this century, you know, in one of the wealthiest nations of the world, you know, we have people who are living, you know, a few miles apart, but having very different experiences with respect to health and health outcomes. And so I shared with you before the definition of health according to the World Health Organization, but also included in their constitution was this idea of health as a human right. And so the preamble states that the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being without distinction of race, religion, political belief, economic, or social condition. And so we know, particularly in the US context, you know, health is very politicized. We have people who feel that access to healthcare is a privilege, and then others who think that access to healthcare is a right. And I want to make the distinction between healthcare being services and health as what many people said is a sense of peace or a sense of well-being or a sense of access to services or access to fresh fruits, because food is medicine. And so I just want to, you know, just reflect on health as a human right, and really again to highlight, and we'll talk more about health disparities later, that even though there's been this statement again from the preeminent international organization focusing on public health, you know, that health is a right, that's not what is experienced by millions of people, billions of people, I would argue, around the world, that they don't enjoy health regardless of their race, religion, political belief, economic or social condition. In fact, those very things create differences or disparities in health outcomes for billions of people around the world. So, you know, what are kind of some of the driving factors between these health outcomes, and particularly the differences in health outcomes? And so I use the word differences here in the title, but this is where we're talking about health disparities, why we see differences in one group from one group to another. And so often that is fueled by the distribution of power, of money, of resources, because they determine the social, political, and economic environmental conditions that are experienced not only within a population, within the District of Columbia, within the city of Bexley, within the city of New Orleans, but across populations. So within the District of Columbia, how might different racial or ethnic groups be experiencing these conditions? And so some of you highlighted even within, you know, Columbus or within the borough of Brooklyn, it's very large, and just being in that space means that you're going to have different experiences based on what neighborhood you live in, perhaps even what street you live on. And so this unfair distribution of power, money, and resources creates, and this is what's most tragic to me, really avoidable health inequalities, also known as health inequities. So I think of what's called social determinants of health as really social drivers of health inequities. And so I will, stand behind this statement and encourage, reflections. I think particularly in the United States, also what's driving health inequities is structural racism and the conditions that perpetuate disparity. And by that, I mean economic disparity or poverty. And so there are some words here on this slide that I want to provide some definitions or some thoughts, and again, encourage you to push back and add different contexts or how you are thinking of them. So first, the idea of equality versus equity. I think sometimes in public discourse, these terms are used interchangeably, and that's generally not correct. So this is a graphic some of you may have seen before to describe the difference. So 3 spectators at a baseball game on the other side of a fence. And so equality says, regardless of your height, you get the same box. So I would say perhaps the adult in the picture, could see over the fence with or without the box. And the younger people in the photo, based on their height, needed a boost to be able to see over the fence to enjoy the baseball game. But still we see in the equality section that the person on the right, despite getting the boost of the box, still is not able to see over the fence. So in that case, what is considered equal treatment still leads to disparities. We still have someone who can't see over the fence. And the middle panel, what equity says is essentially people get what they need so that everyone is at the same level. And if disparities exist, and we know that they do, that means some populations should be getting more support, more resources than others, if what we're truly trying to achieve is an equitable system. That equality will not get us there. It won't help everyone in the same way, even though there is some support. Equity says that everyone should get what they need, and that might look different across populations because people are starting at a different level. And so often I think moving to the right, what's left out of this picture often is people don't comment on the fence. Like, why is there a fence? What is the fence about? And I would say the fence is, the structural discrimination. The fact that we need the boxes is because of the fence. But if we remove the fence and then the boxes are no longer needed, perhaps that leads to a sense of liberation. And so I would say, again, on a continuum for me, in my work in public health, what I'm trying to achieve, or at least call attention to, is the fence, and then achieve a removal of the fence. I know that's a very simplistic view of a very complicated, complex, heavy historical view of health, but I find this illustration to be more accessible. So I'll stop there in case anyone has any comments, or in case anyone is seeing this for the first time, if you have any reflections on this graphic, which I did not draw, this is not mine, but it's something that I've seen, in many presentations. So I'll stop for a moment in case anyone has any thoughts.
Erica, yes, I've seen this many times. And so, we as teachers think about this all the time. And this is what we do. I mean, this is the work that we strive for. Our classes are full of lots of different types of learning styles and lots of different types of kids with lots of different types of backgrounds and lots of different type of issues. And I could go on and on. But our goal, but I did like the fact that you talked about removing the fence. I've really seen the drawing with just the equality versus the equity, but the removal of the entire fence, I really like that, metaphor for, what that can mean for all students.
Any other thoughts? Okay, I'll move on to the next slide. But again, if you think of something, we can always come back.
Eric, let me just go back to the fence.
Okay.
Been reading in this time about the redlining in communities that I really didn't understand fully. I'd heard the term, but didn't realize the total implications. And this removal of the fence is another very subtle but very obvious way to deal with redlining. And so, you know, making the barrier so that people absolutely have no access.
Hi, Mrs. Microns. And I would encourage those of you who are interested in learning more about redlining, which was a federal housing policy, and how that led to segregation with respect to housing for people of color. I would encourage you to read a book called The Color of Law. It's a comprehensive kind of review of what led to that policy and how it was implemented and the impacts that we still see on communities today. So thank you, Mrs. Microns, for that comment. Okay. I'll move ahead, but again, we can always go back. In the previous slide, sorry, 2 slides ago, we talked about structural racism as a driver of health inequities. And so I wanted to provide some definitions here, and again, encourage thoughts and reflections, and please push back. And again, want to say, of course, this is incomplete. Any one of these slides in this presentation, there are courses, books, journals built around this work, and I know that we just have an hour together. I just wanted to provide an overview, but there are 3 relative levels of racism, and I would say in the public discourse, when people often say racism, I think what most people mean is personally mediated racism, but I'll walk through these 3 levels quickly. So institutionalized racism, so again, to the example of redlining, that was codified in laws and practices. So this is racism that is perpetuated in essentially inner institutions. That's where it gets its name. And it creates differential access to goods, services, and opportunities. And it's somewhat normative, so it becomes part of the culture of a society and sometimes legalized. And it really manifests as an inherited disadvantage. So the discrimination that my grandparents experienced in Virginia growing up in the 30s and 40s, I inherit that disadvantage by virtue of my lineage. But some of the same policies, many of the same policies that impacted their livelihood and well-being also will impact me. And again, institutionalized racism is often codified and implemented as customs or practices or laws. And the tricky part about that is it's hard to then identify a perpetrator. Like, the government is racist, some people may say, but you can't point to a particular person all the time, which makes addressing the racism that much more difficult if you don't have a person or an institution that you can hold accountable for addressing that racism. Personally mediated racism takes a form of prejudice or discrimination, the difference there being that prejudice is about differential assumptions and discrimination is about differential actions. And then internalized racism is about acceptance by members of the stigmatized races about the negative messages that they're hearing about their abilities or their worth. And then the next step is like accepting those limitations as true, because that's what they're hearing, in society about people who hold their particular identity about, again, their worth or their ability. So I'll stop there again. If there are any reflections, if people think about this in a different way, if this is the first time you're seeing racism described in these 3 levels, I'd love to hear your feedback.
Dr. Reaves, this is Brandy Slaughter again. I think one of the things that and that's important to me and has been a focus of my work over years of advocacy is around health insurance and its role in making sure folks have access to services. Could you speak a little bit about how that fits into your frame?
Sure. So I'm going to speak first. So, for instance, I have a background in Medicaid policy. Medicaid is a health insurance program for people who often qualify on the basis of their income level or disability status. And so there is an association, at least in the United States, between race or ethnic-based discrimination, employment, and therefore income. And so then, ability to access health insurance, whether it be employer-sponsored health insurance or Medicaid, or the ability to pay for health insurance out of pocket. So if health insurance, impacts one's ability to access care, and you kind of create a dotted line through all of those factors, it's not surprising to me that we see that many of the people who remain un or underinsured, and by underinsured I mean their level of insurance doesn't meet their needs with respect to medical care, that disparities persist. So we have the Affordable Care Act, which expanded Medicaid, to certain populations. There was a Supreme Court case or cases. One of the cases said basically that the federal government could not mandate that states implement the expansion. So even though there was this landmark case with respect to health insurance, many people remained uninsured. When you map the states that decided not to implement the Medicaid expansion, you see that many of the states are what we would call red states. And then when you see the communities most impacted by the state's decision to not take up the expansion, that many of those areas have a plurality or majority of people of color. So again, this is kind of across what I would say maybe are the top two levels, institutionalized and personally mediated racism, that you have, a political force. That's a political decision, informed, of course, by economic considerations. But the conversations that happen in the White House, in our state houses, in our city halls, impact our health because they're making decisions about access and about practice and about custom and about law. So I know that's not a specific answer to your question, and I'm happy to look into that and get you more information, but just wanted to bring it back to kind of this theme about unequal distribution of power and resources and how that impacts individual health. Great, I'll move on. Again, we can always come back. And I know I'm throwing a lot of information at you, so thanks for hanging in there. So I'm not gonna step through all of these, but I just want to highlight there are many other conceptual models, which again are trying to summarize a lot of complex information, a lot of information that's in flux, a lot of information that looks different from city to city or state to state or country to country. But just to say, as we get more information, a model provides us with a framework to feed into as we get new information or to question our assumptions about the relationships between all of these moving pieces. So this conceptual model is trying to, draw the dotted lines between, the economic and political context, one's social position based on their education level or occupation or income or gender identity or ethnicity or race, also what's happening with the healthcare system, and then the influence of distribution of health and well-being and how health and health inequities feed into all of that. So I'll move on to another model, and again, this will be available later, which again just tries to capture some of the same information just in a different way. So this is highlighting what many of you shared earlier. The health is impacted by access to food, by stable income and job security, your environmental quality, your neighborhood conditions here with respect to lighting, your ability to afford healthcare, educational opportunities, access to safe and affordable housing, and also to the extent that you experience discrimination based on any number of identities, race, ethnicity, gender, sexuality, ability, and by that I mean physical ability, English proficiency, in particular in the United States. There's discrimination around these identities, and that has to impact your stress levels. And so for some people, this is an everyday thing. All of these factors are impacting all of us, but for some people, when their job isn't stable, when their environmental quality is poor, when the neighborhood conditions aren't safe, when they can't afford healthcare, when they don't have access to education, you know, when they're housing, someone mentioned asbestos and lead, when the housing isn't safe, that is a constant stressor impacting one's health and well-being. Again, another model which along the bottom goes from emerging public health practice to the left and current health practice to the right. And what this model is saying that we tend to focus on, you know, infant mortality and life expectancy, disease and injury, and risk behaviors, which of course are all important. But if we're going to move towards a more equitable system, we need to consider those factors, as well as our living conditions, as well as how our institutions perpetuate inequities, and also social inequities. And again, with the arrows, trying to capture how all of these factors are at play with each other and how things shift over time. So another opportunity for personal reflection, and again, feel free to share or not. Just wondering how this statement hits you. Social factors, including education level, race and ethnic discrimination, social supports, and poverty result in avoidable suffering, disability, and death. So I'll just pause for a moment. Any thoughts or reflections?
We'll chime in. We'll bite. My mom and I are sitting down here, and it's obviously hard to disagree with. Obviously, as you've walked us through all of the different components and aspects, I think the avoidable suffering, disability, and death is pretty hard to argue with, just based upon the broader discussion and the argumentation that you've laid out.
I think you could put this personal reflection question next to the pictures of Baltimore and New Orleans and the zip code differential in life expectancy, and it's quite clear what happens in the inequities and avoidable suffering and disability.
It really does paint when you look at this one statement, it is amazing just how quickly everything, you start to see things from a perspective of like you're outside looking in. And for me, this was very stark, and things that I, have knowledge of, but you don't necessarily contextualize in one place. So for me, it's kind of like, like hitting a brick wall. Like, yeah, that's what it is.
It's Jill Levy here. I see it reflected incredibly right now with the what's happened with COVID-19, with what's happened with this particular pandemic, and how it is showing the inequitabilities of all of this.
Any other reflections?
My comment, Erica, this is Brandy, is, when you're engaged in this work and you see these data points, COVID is definitely something that has flashed a light on these disparities, but certainly the data points go back years and years. You know, infant mortality rates high, higher in Ohio than, you know, Mississippi, I think at one point. You know, maternal morbidity, you know, like the terms of how many data points that we could all run off about how people of color are disproportionately impacted by not only health, but criminal justice, education, like it runs rampant. I just wonder, when I see your personal reflection here, what is it that we can do to get people to understand? This is not a disproportionality that hasn't existed a long time. And certainly with a COVID epidemic, a racism epidemic that's high in people's mind, you know, maybe people are coming to awareness, but I wonder what it is we need to do as advocates, as people who are concerned, to get people to understand the severity of this. Because the reality, Dr. Reaves, is this data has always been here. The history about redlining has always been here. This is not new news. So how do we take this and make people understand and care and move forward policies that can begin to turn the tide?
Yeah, thank you for that, Brandy. I actually have a slide on that coming up. So I'm not avoiding your question. I'm just going to hold it because I'm going to actually try to end with some action steps. But thank you for setting me up. I appreciate that. So just noting the time, I have just a few more slides, but I'll move us forward. But of course, we can always come back as you have additional observations. Sorry, my computer's frozen. Oh, here we go. So, and someone mentioned, you know, COVID-19. And so I, of course, want to, you know, bring us back to, you know, the title of the session, and also, you know, can offer a bit of a case study. Again, bringing together social determinants of health. Again, I call them social drivers of health inequities and health disparities. So there's a really wonderful account on Instagram that I follow called Phenomenal, excuse me. And this was a post from 4 days ago, which reads, Black and Latino people in the US are 3 times as likely to contract COVID-19 than their white neighbors, and nearly twice as likely to die. And so just wanted to highlight a few points here, but first want to give a moment to reflect on the weight of the experiences that people are having that led to a post like this. Again, the avoidable suffering, the avoidable death, the ways in which, you know, communities were ill prepared, either because, again, of a differential in resources or in power. I mean, how this is impacting people's everyday lives. And to Brandy's point, COVID-19 is one of many conditions where we see a disparity between what people of color experience with respect to outcomes compared to white counterparts, and trying to understand how those differ because of the social conditions and not because of what most people, some people think of as like inherently a biological difference between people of color and others. There is a lot behind this number that we could address, but perhaps in different areas, you know, the opportunity or the political will has not always been there to get at the downstream factors that have led to, you know, what is, in my opinion, a horrific outcome. So I just wanted to note that we can only get information like this because we have to force, you know, hospital systems and physicians and others to capture race and ethnicity data. If we didn't have people capturing that information, we wouldn't be able to provide these numbers. And so there's always an issue with data collection. And so I feel like there has been some movement in that respect with respect to COVID-19. And now there's a tracker that looks at this information by race. But to get to this particular meme, as it says in the first bullet, the New York Times had to sue the Centers for Disease Control and Prevention to get this information, to be able to pinpoint what the experience has been with respect to infection and death rates due to COVID-19 for people who identify as Black or Latino. And so as of maybe an hour ago, when I checked, we're at over 134,000 deaths in the United States. And Black people in particular accounted for 23% of deaths. And of course, that's where race is known. For some people who've unfortunately passed due to this infection, we don't always have race information. And so we can only report what we know. And so on the heels of, I think, what is kind of a renewed, energetic call for social justice reform, which has always been happening for centuries. You know, there have been some local and state leaders making a movement to declare racism as a public health crisis or emergency. And you can follow this link here. I think at last count, there were 17 states in which either the state or a city council or some other municipality had decided to declare racism as a public health crisis or emergency. And I think it's worth noting, a bill was introduced in Ohio to declare racism as a public health crisis. And had the bill passed, Ohio would have been the first state to declare racism as a public health crisis. So I'll stop there, particularly if there are any reflections on COVID-19 or anything from the presentation in the context of COVID-19. Okay. So I'm gonna just end the formal part of the presentation with this is truly a personal reflection. These are my words, and to give some context. I am a public servant. I work for a government entity, and as I mentioned, many of you are having, conversations not only about COVID-19, but the movement in the week of George Floyd's murder in Minneapolis on May 25th, and others who have died at the hands of police, and the call for police reform due to brutality. And so some colleagues, we were having, a conversation, and I'm not one to shy away from uncomfortable conversations. I honestly think that this presentation and all presentations, are a reflection of value statements and what I hold to be true and important. But of course, I always welcome, feedback. That's part of my learning. But it's weird to say my own words resonated with me. Of course they would because I wrote them, but I keep coming back to this because I've had to basically say some form of this in many spaces. And so I'll read it and then of course ask you to share if you'd like. So I wrote in early June, the collective uprising and its public health implications are all I can think about and all I have thought about for days. In the spirit of full disclosure, being present at work today is tremendously challenging for me. To that end, I request that we, as colleagues and public health servants, be more thoughtful in sharing our views opinion as certain words, for example, riot, or characterizations of the uprising are triggering for others. As someone who identifies as Black, I feel anger and anguish that Black people and allies feel compelled to protest a pandemic that is disproportionately killing Black people, to protest police violence that is disproportionately killing Black people. I acknowledge and understand the full range of reaction to yesterday's events in Boston, example, looting, noise, trespassing. But I think it must be said that the current civil rights movement is grounded in justice, equity, peaceful protest, and civic engagement. While the violent scenes from this weekend, many incited by police and persons looking to usurp the movement to advance their own agendas, are disturbing, there's no perfect way to protest 14 plus years of systemic racism and state-sanctioned violence. And so to Brandy's question about, next steps, whether you identify as an ally or an accomplice or a co-conspirator, or are new in your journey in addressing social justice, social injustice. I offer this model of like health promotion as a way to move forward. And Brandy, your question was like, what to do next? And so this offers, options to strengthen communities, to develop personal skills, to create supportive environments, to reorient health services, or to really advocate for people and their services and their needs. And so I would say, of course, continuous learning, being open to different schools of thought and different experiences. But again, as someone who works in communities, I try to enter without assumptions, and as much as I can to include those who are actually living the outcomes that I'm hoping to study, including them and helping me understand what the issues are, what the solutions are, what's been happening in this community, what's worked, what hasn't worked, who is the person that I need to talk to when I need this information. And so to bring people along, there's a history, particularly in communities of colors, like being studied, being worked on, being observed, and not being included in developing the solutions or framing the problem. So I think, next steps or continued steps, of course, can continue learning, reading, engaging, participating in events like this. But as you look for ways to support your community or neighbors or others, to enter, with humility, and to enter knowing that you're there as a partner, not always there to lead. And of course, if that's not comfortable for you, or you feel that you're not in that space, to the extent you're comfortable donating, other resources such as time or money to support the programs and efforts that you think will do the most good. And so with that, I will stop. Almost right at 2 o'clock, but of course I'm able to stay on a little bit longer, but welcome again your thoughts, reflections, or comments.
Erica, thank you. That was terrific. As someone who's known you since your days at CSG, I am one very proud alum. Thank you very much.
This is my turn.
And I'm a very proud former teacher. So thank you, Dr. Reaves. Congratulations to you.
And Dr. Reaves, I add with the kudos. I'm super proud, but of course, ever the advocate. You referenced SDR 14, which is in the Senate. There's also a companion piece in the House. So any of those here that listened and heard and are moved to action, I do encourage you to reach out to the Speaker of the House. Our Representative Erica Crawley has the companion in the House, and it's not being offered any hearings. And in the Senate, it's been offered hearings, but now they're on recess. So if you feel led to just advocate and have something, move you to action, that's something that I would recommend. And thank you, Erica, for letting me give that real quick commercial.
And maybe, Brandy, you can provide that information for the follow-on email that Eris has so kindly and graciously provided traditionally.
That would be great.
I just want to thank Sin for saying what I was about to say. So thank you, Sin.
Thank you, Erica. And I have to tell you that I have a large group of young grandchildren who have been active in every protest march here in New York City. And this generation is going to see that change happens. There is not a doubt in my mind.
I'm hopeful.
I hope so. Hope so. Hope so, Marcia.
Wonderful. And so just in conclusion, does anybody have any other questions or comments or anything else to add?
Well, when I saw that drawing, the first thing I thought about was universal health care. And it seems like somehow we all have to come together and talk. We are such a divided nation that something like healthcare, which is so important that everybody has the right to walk into a hospital and get healthcare. I mean, it's just appalling that people don't go into the hospital because they can't afford it. I'm sorry, this is something I feel very strongly about.
I would say don't apologize. I'm right there with you. I'm in the same camp. And yes, in the US, it continues to be true that access to healthcare remains heavily politicized. You know, and conversations, of course, happen at the federal level and then at the state level. And so Brandy's question earlier about like how do you move, you know, governments to act, you know, in residents or citizens' like best interests. I don't have a magic wand. If I did, I would have waved it long ago. But I think that is the subject of, you know, a lot of policy analysis and conversations and people trying to understand what are the policy levers, what are the statements, what are the data that we need to convince people that everyone should have access to healthcare, when it seems like such a straightforward question with a straightforward solution in terms of developing a program. Of course, there's funding and implementation that goes into that. I don't know the answer.
Well, obviously nobody else does either. But it is appalling that we are the wealthiest Western nation without such universal health care. It's just appalling to me.
Yep.
Okay, well, if we don't have any other comments, questions, anyone?
Hey, Erica, this is Giovanna. I am just amazed. That was wonderful. And I am jumping on the bandwagon, so it seems. So I think that, of course, it's not that I didn't notice these things going on. Absolutely did. And it's hard to be what is considered a minority person and not know that they are going on. I think that COVID has made other people see what we see, which is eye-opening, and it's terrifying for most of us, but it's good at the end of the day because, you know, you never want to be the only people saying, don't y'all see that this is wrong? Look what happened. And everybody's like, I don't get it. Why are you just not happy, girl? You know? And so I think that it has shown and continues to show every day, even now more, that the surge is coming back, that there are disparities and that we need to come together and do something about it. Now, where that will lead, I have no idea, but I am glad and super hopeful that this is going to open up some eyes and make some change.
Giovanna, just a follow-up comment. You know, my take on it, particularly before, you know, I went back to school and really studied public health more formally. You know, a lot of the conversations about disparity were about data, which means they were happening at think tanks and, you know, at universities and people who did research. And so it was the research people talking to the policy people, and we were leaving out, you know, the public, so to speak. And so I think to your point about what COVID-19 outcomes have laid bare for the country, I think people are realizing that there are more actors who need to be involved in these discussions and these decisions, and people can see, you know, what they maybe couldn't see with cancer or cardiovascular disease outcomes, they can see with COVID-19 outcomes because they know what's happening on their street, in their neighborhood. And so to your point, I agree. It feels like there's a heightened awareness. and now the connection to social justice, I think will just continue to make for a very powerful movement. And hopefully as we move into, election cycles in the next, year or two, that people, whatever their views are, take the opportunity to make their views known by moving with their feet or moving with their vote. So I'm hopeful as well.
Okay. If there is no other, if no one else would like to jump in at this time.
We could go all day. I'm telling you, it was really difficult to try and get it into an hour. We could talk for days.
No, we could continue. No, we could continue the conversation. We could, I just want to make sure that everybody, has had their opportunity. And yeah, I am, Erica, I want to thank you so much. This has been so, going into this, I personally had I would say a baseline of knowledge. And this hour has just been so, it was like a packed with protein punch. Like that's the only, it was like it's got me going. It's given me energy. And so for that, I am very grateful and appreciative. I'm sure I speak for many of our, fellow alums here with us. And I feel pretty confident, I should say, that you all too share the sentiment. So thank you so much. And I just want to let everyone know, as Sin very astutely pointed out, that yes, there will be a follow-up email, as there always is. And I will have information to you shortly so that the conversation can continue. You can continue the conversation on your own, with friends, with family. And we're going to continue, obviously, continue with COVID and coffee. And again, Erica, thank you so much. And at our next episode, which is episode number 4, we'll be seeing Giovanna Moxley Knapp with storytelling, advocacy in writing as activism. So I look forward to seeing all of your beautiful faces there. And thank you so much for being here, for joining us. And until our next episode, here's to the project, here's to the work.
Thank you, everyone.
Thank
Wishing you health and wellness. Thank you.
Good job, Erica.
Thank you.